Hey, it's Phil from Podiatry here. So I'm just doing this quick video on tips that I've learned from doing 3,000 PNAs over the last 20 years. So I'm hoping this is useful to some new grads or maybe students, third, fourth year. Nail surgeries can be kind of terrifying. It's probably one of the things that most podiatrists leave uni most afraid of, that and doing anything with MSK. But surgeries, let's talk about things that I wish I knew when I was graduating. So you'll see nails like this all the time as a podiatrist. They'll walk in your door every day. So you've got to have a bit of a strategy for them. Obviously, conservative treatment is always an option. And it's kind of preferable to do that initially if you can, particularly if you think it's just a one-off thing. So it might be, you might get the teenager who's been playing footy in a pair of tighter boots and just got up like the nail edge is pierced through. So I'm probably not telling anyone anything new here, but if you're a new grad or you're early in your profession or finishing your studies, hopefully this is useful kind of information. Just removing that spicule can be really helpful. So I love using little beavers, little chisel blades. But I know Gracie, one of our podiatrists, was just a massive fan of using the number 15 back, upside down. So, it doesn't matter how you do it, but just getting that corner out is really helpful. And then some follow-up care to just topical antiseptic. But look, the PNA is a really useful skill. And as podiatrists, I believe it's one of the best things we can offer to people in our community, because GPs aren't very good at it generally. Probably we're the best placed people to do it. So generally your PNA is obviously a partial nail avulsion with phenolization. That's usually what most of us are doing, using phenol or something else. So yeah, remove it and phenolize it. Now, things that can go wrong. So these are the things that I wish I knew when I was starting my career. Incomplete anesthesia. So if you can't numb it, it's going to be difficult. Now, there's lots of reasons why that may be difficult. Its technique is important. So obviously position the injection site appropriately so that you can get the correct block of the dorsal and plantar nerves on either side. That technique can be kind of difficult. You want to get enough volume at the top and the bottom so that you can get a complete block of it. Sometimes that's scary, so your patient will be afraid, and needles hurt. I'm not sure of any way to do this without any pain at all. There's always some pain involved. One of the tricks that can be useful, I've been a bit of a fan of these tiny little 27 gauge half-inch needles. Now, obviously you're not going to do the whole block with that, but you can get that in without a lot of pain and inject just like about 1 mil initially on each side. What that allows you to do is you do that quite quickly, and the patient can then relax, and then you can complete the block with the normal length, 1.25 or whatever it is most of us use, with much less pain, and you'll be able to sort of advance the needle down and get that complete H block done without much pain. So that's a trick that I've found useful, but others, other people have other techniques. I rarely do that, but it's more for patients that are really needle phobic. They're willing to do it, but they're really afraid of that needle. It just allows you to give that first injection in a couple of seconds on each side, and then the needle's out, and it allows some anaesthesia for you to come back and do the second injection later without much pain at all. You often don't even feel it at all then. So yeah, just be careful with that. There's a lot of other techniques too that perhaps we should chat about at some stage of how to calm patients pre-injection. Vasovagals, which is where people faint and get scared, it's often the actual needle that scares them and that gets them sort of heightened. So if you can just settle them, that's really helpful. And some of those skills are more sort of softer skills. I've done a bit of research into some sort of hypnosis techniques. It's more just about pace of speech, explaining what you're going to do. Tell them that it's going to be painful, but they're going to be able to handle it. That sort of stuff, really helpful. And lead calmly to the patient. If you're fired up and excited, they are going to pick that up. They sniff it like a blood in the water. If they're a shark, right, they can sniff it, and they know if you're scared, they'll be scared. So easier said than done. Now, the other thing that goes wrong with surgeries is not taking enough nail when you do the PNA. So you got to be cautious of that. Hopefully you can see this. I'm just going to try and draw a line. So when you got a nail like this, if you're not taking enough nail, once you've done the procedure, and obviously you've got nail going back to about there, but if you're taking that piece of nail out, if you haven't taken enough margin, as the nail regrows, it's often going to regrow in. Now that's more important for those chronically involuted nails that are curling in, that you know it's going to sort of keep happening again and again. So make sure you take enough margin so that you don't have to repeat this procedure in 3 to 6 months, because patients won't like that. The other issue is taking too much nail. So if you take too much nail, they have this really funny looking toenail for the rest of their life. And a lot of these people you'll be looking after, they might be teenagers, you know, and I'm always cautious. I don't want to give a 14-year-old girl a really funny looking toenail for the rest of her life. So that's really your job, is to make sure that you get an aesthetic result as well. Yeah, so don't take too much off. So if you start taking a large, I can't get my drawing to work. If you start kicking a big, large chunk of nail, that's going to look, you know, kind of unusual. One trick that I have found is helpful is sometimes you want to get quite a large margin, but you want the nail as it regrows to grow out at a volume, at the right sort of thickness. Particularly if there's a fair bit of hypergranulation that you know is going to settle. What you need to consider is the width of the nail at the matrix here. Right? You can do quite an angle, but then only phenolize that thinner position up here. So consider that as definitely an option. What you phenolize is what's going to grow out. So this nail here is essentially going to grow out at this width again. And that sometimes can be a technique for something with a lot of hypergran, or that you know is going to settle and reduce. So anyway, they're my tips. Another trick that I like to do in my procedures too is to really reduce recurrence rate, is to really be cautious with phenol application times. I'm not sure what they're teaching at uni these days, but there's a study from not that long ago, 2021 actually, where they sort of compared phenolization times. I would probably consider, they say up to 60 seconds of phenol application time. It does slow down the healing, but it definitely reduces the recurrence rate. And for me, I'd rather have that. As long as it's someone healthy who's going to recover from it, a little bit longer healing time is better if we're going to get a reduction in recurrence. You don't want a recurrence. And I like to use a curette so once you've phenolized, is to actually use a little curette to scrape the matrix as well, just a little bit, just to help to remove those germinal cells from the matrix. It just seems, in my opinion, just seems to reduce the chance of recurrence. Okay, so hopefully that was useful to at least one person. If it was, that's good. And if you're, you know, an expert who has a different opinion, I want to learn. I want to know if I've told you something wrong or there's a better way to do something. Yeah, let me know. But yeah, bye.